My type A weekend warriors who are 45 years old, we need to focus on recovery. We need to help them to rebound faster before they load up again. So they may need to learn pacing strategies in addition to metabolic recovery strategies. So there's a psychological component. Our sensitized patients, who the trainer isn't going to see, but the clinician will see. These are our chronic basket cases, who associate every hurt with harm, who are hypervigilant about pain and have now one big pain amplifier. So non-noxious stimuli is falsely interpreted as threatening to them. They require a more clinical approach, so they're more at the pain management end of the spectrum, where we need to give them graded exposures to low-load exercises like Professor McGill's exercises, so that they can learn that the things that they were afraid of are actually not only not threatening, but when they start to train properly, they actually become more stable, and they realize that they're not as damaged as they thought. That when they were told they had a ruptured disc and there was no solution short of surgery, lo and behold, all of a sudden, they're getting an empowering message that there's something they can do for themselves. So the strategies that you employ are open-ended. I'm giving you the goals, and you can apply them in any manner that you like, as long as you're measuring capacity, assessing demands from your history, and identifying a capacity shortfall that's patient-centered. This isn't something that can easily be studied statistically in a randomized controlled clinical trial, because in order to get a grant, you need to have a big RCT with a large population, and now automatically you're assuming that everybody is alike. And unfortunately, in a large population of a couple thousand people, which gives statistical power, everybody is different. And so you have some people that are extremely rigid and tight, and you have other people that are Gumbies, and you're putting them all together and assuming that it's a homogenized group and applying the treatment and seeing what has more effectiveness than a placebo. But if some people need more WD-40 and some people need to be tacked down, and you're applying just WD-40 treatments to everybody, then of course the WD-40 treatments don't work. And so you show that the treatment is ineffective. The modern approaches are subclassifying people into different treatment groups. But the grants don't come easily for those studies. Those studies, and Professor McGill, 2 days ago, at his lake house, north of here, I believe, with Jeff Kubos, was telling us how much of a novice he feels in the scientific arena. And why would Professor McGill say that? I mean, I think it made Jeff and I take a step back. I mean, the humility of our greatest spine scientist on the planet to say that when he's around other researchers and they ask him to prove his data, he realizes that he's really like everybody here. Even though he's not a clinician, he actually thinks like one of us. Because for him, it's that patient before him. And every patient is unique, and every patient needs to be unmasked for what their challenges are, and for what their capacities are, for what their shortfall is, and what their unique treatment solution is, which we'll never know until we actually we have our theory. But until we actually audit empirically, we still don't know whether or not our hypothesis was correct. So the real science, the scientific method, is nowhere greater than when n equals 1. And that's a patient-centered practice. It may be based on evidence, but I wouldn't say it's evidence-based, because evidence-based treatments are based on treatments that have been studied in large RCTs where everybody is considered to be the same, where low back pain is called non-specific. And everybody gets the same lowest common denominator care, which would never earn me a referral from any of my patients. I'm looking for the unique solution for that individual, and they tell me, I don't tell them. I can't predict it. I do my assessment, do my due diligence, and then I form my scientific hypothesis that I want to assess. And so I find what's provocative, and then I find what's dysfunctional, and then I prove what's dysfunctional using my art, my combination of relaxation and facilitatory strategies, until the dysfunction is now functional, the relevant dysfunction is now functional, and then I have to re-audit their provocative behavior. And so when I'm re-auditing their provocative behavior, I'm moving away from the Yonda, McGill camp of treating dysfunction, and I'm putting back on my McKenzie hat, and I'm auditing the provocative movement. So the means to the end can be Grassman, it can be laser, it can be Rolfing, it can be chiropractic or acupuncture. That doesn't really matter. That's a personal choice. And hopefully your armamentarium is broad, so that if one thing doesn't work, you can try another. And we're tinkerers. When I worked with Carol Levitt, the first time I saw him in 1990, the first time I saw him in Prague in 1990, he was in his clinic, and I got to spend a few days with him, and he would sit at his desk, the patient would come in, he would take a history. His history was like 20 minutes, just the history. And then he would write things down in his typewriter. Nice kyphosis, lean, pecking away. And he was asking the person about their history. When the pain started, he wanted to go all the way back to the beginning. What was the injury? Was there an injury? When did it start? How has it evolved? When did it get better? What made it better? Is it getting worse now? When does it affect you? What are the things you're sensitive to mechanically? What treatments have you tried? And then he would start his assessment. And his assessment was of the locomotor system in the broadest sense. He would assess movement, he would assess trigger points, tissues, strength, flexibility, coordination, and then he would form a hypothesis. So this is the scientific method. We form a hypothesis and then we have to test it. So if he theorized that somebody's neck problem was due to a forward-drawn posture from prolonged sitting, and in the forward-drawn posture he knew that this would lead to a lot of hamstring reactivity, and that would affect the fibular head, and that the fibular head is one of these kind of keystones in the cybernetics of the locomotor system, that if the fibular head becomes locked, that keeps the hamstring tight, no matter what sacroiliac adjustment you do, no matter what trigger point work you do on the myofascial sources of that person's pain in their neck, no matter what adjustments you do to their neck. So in his algorithm, he might hypothesize that I think the fibular head is the key link. And he would assess it and find if it was particularly blocked, that he wanted to adjust it or mobilize it. And so he would test his hypothesis. You might go to the foot and say this person needs an orthotic. Or you might go to the sacroiliac and say this needs to be capitated. He might go to the fibular head, but after he goes to the fibular head, he doesn't know whether his hypothesis is correct until he mobilizes it, and it's mobile now. He successfully mobilizes it, and then he goes back and he rechecks for the trigger point, the jump sign, the twitch response. And if the twitch response is gone, then he feels like, hey, I found the drive point. I found the key link. It's upstream of the problem. And on the audit basis, it removed something at a distance. And that's why he said, and we gave you the slide yesterday, he who treats at the site of pain is lost. So we use our strategies, whatever they may be, as means to an end. The end is to reduce the patient's activity intolerances, which we won't know about until they return on the second visit. Our best guesstimate of within-session changes in a person's activity intolerances is, between session change and activity intolerances, is what happens within the session in terms of the provocative behavior of the symptoms. And that was McKenzie's contribution in the universe of musculoskeletal pain management. That within-session audit of provocative behavior of symptoms predicts long-term recovery. And so we have to identify the painless dysfunction, we have to identify the provocative movements, and we have to identify the patient's activity intolerances or goals. And when we know those three things, we can apply a clinical audit process, which is what I'm teaching. Okay? And you can use any tools of the trade that are your preference. It's patient-centered care.